Okay, welcome to Friday Afternoon Cocktail Hour with DDS. Today we've got Prof. James Mah, all the way from Las Vegas. Did I get that right?
Yes. That's correct.
Joining us from Las Vegas, and of course, Dr. Bowles, we all know him. We're going to go through a little bit about ClearCorrect. So ClearCorrect is Straumann's answer to clear aligners. And Prof. Mah is going to detail the system. He's going to tell us what's great about it. Thank you for joining us, Prof. I think as a start, maybe let's just hear a little bit about yourself, and then we can take it off from there.
Great, thank you for the introduction. Let me start by sharing my screen with everybody.
Let's go.
Okay, I think we're up.
Yes.
Well, very good. First off, welcome everybody. Thank you for taking the time to listen to this presentation. I hope you'll all learn something from it and be able to apply it to your clear aligner patients in your office. I think what we could do is just start off a little bit about myself. What can I say? I wear many hats. First and foremost, I'm a professor and I'm also the program director in orthodontics at the University of Nevada, located in a small desert city in Nevada called Las Vegas. I just want to say that I've been involved with digital dentistry for over 25 years, and I've done a lot of research in clear aligners, the biology of tooth movement, and cone beam CT imaging. In my research endeavors, I've actually participated previously as a consultant for Align technology in the early 2000s, and also served as, was a principal investigator on some of their research projects. But more recently, I've been working with ClearCorrect as first a consultant, and then also more recently as their chief R&D officer. The other hats that I wear is I'm an editor of several journals. I'm an associate editor of the Journal of the Aligner Orthodontics, and also a reviewer for the Journal of Clinical Orthodontics, and also the American Journal of Orthodontics and Dental Facial Orthopedics. So in today's presentation, I've got it in four pieces or four chunks. I'd like to share with you first a bit of evolution of the clear aligner therapy. The reason I always start with this one is there are some valuable insights early on that people have written about and talked about years ago that today we still are not implementing in our aligner treatments. Next, I'll talk about the advantages of clear aligners and ClearCorrect aligner system. And the third topic is I want to hone in on the design of an aligner, and specifically the ClearCorrect trim line and how that makes a huge difference. And lastly, I'll show some case examples of treatment with the ClearCorrect appliance. In the first piece, when we talk about evolution of aligner therapy, not surprisingly, aligners have progressed and advanced just as much as fixed appliances, dental implants, or anything else you look at. I think everybody would agree that, for example, dental implants that are from 5 or 10 years ago are not the same implants as they are today. And we see the same trend here. There's continued advancement. And it's good to walk through that and see where we came from, what kind of journey aligners have taken, and also where is this going? What is the future of aligners? And this is a point in my presentation where I start to lose the audience, because I often ask people, who remembers the 1960s? And then suddenly reveals my age. And then the rest of the audience is, man, this guy's old. Yeah. But it's an important time because I want to go to the next slide. In the 1960s is when clear aligners were first introduced. And I have a picture of Dr. Henry Nahum, who was the chairman of the orthodontic department at Columbia University at that time. He is the inventor, and in my mind, the father of clear aligner therapy. He created a device that I think all of you have used, and you have it in your offices today, and that's the common vacuum forming device. And he reported that in 1964. In this publication from the New York Dental Journal, he was the first to describe a cosmetic invisible appliance. He worked with plastics that were used in packaging for toys and hardware of different thicknesses and materials. And what he described in 1964, the choice of using various plastics, acetate, butyrate, polycarbonate, etc. He had a long list. We've not fully researched and looked into the depths of each one of those plastics, yet they all are clear, invisible type of plastics. Moreover, he also experimented with different thicknesses of these materials at different times in treatment, which makes a lot of sense. As you get more experience into aligners, you start to appreciate that the thickness of the material has benefits in certain situations. But he also talked about ways to help seat the appliance. And although we don't do that today, a very important function of aligner therapy, or important aspect of it, is that it be seated. Today we have patients wear chewies or use chewies or bite sticks, or what we call them, to continually seat the appliance. But in the 1960s, he instructed patients to eat with the appliance to help seat it, because that is a key mechanism of how aligners work. They must be seated. And then he went on to describe how it could be modified for use or with headgear for class 2 correction. And then lastly, also use in restorative dentistry for the production of provisional restorations, where the aligner was used as a matrix or a shell to make the provisional restoration. So he went a long way with that. And since that time, there's been, at least in North America, it was an idea that was adopted very well. And people, and aligner societies, positioner societies were created. But then fast forward, the orthodontic attention span was taken over by fixed appliances. And then fixed appliances dominated for the next several decades until we got to, and maybe this is where I get the audience back again, who remembers the 1990s? Surely you must remember the 90s. And the 1990s were, I guess, the dawn of the digital age in dentistry, where it became more mainstream. And at that time, innovators took the principles that Henry Nahum had laid out and say, hey, let's see if we can do the same thing with digital means. We have a digital model. We can move the teeth independently on the computer, and then we get into computerized assisted manufacturing and so forth. And that was the dawn of the modern day digital aligner system. But like many things in the 1990s, there was a certain amount of bravado associated that digital would be the cure-all for everything. If it was digital, go no further. It was perfect. And in the advertisements, people even said, like, traditional brackets and wires, that was going to become the equivalent of the horse and buggy. It's going to be antiquated. And that was what it was said in the right around the late 1990s. But the problem with this kind of representation and marketing, particularly to patients, is it led to high expectations, and people thought it was an easy thing, and then they got into it. And one of the biggest, myths in the aligner world, and it still is perpetuated, is that a patient simply wears a series of appliances on a prescribed schedule, and then insta presto, voila, they have a pleasing correction to their malocclusion. And I use the word myth because if we look at the literature, it rarely, if ever, works out that way, perhaps in very, very minor malocclusions. But in most cases, you need a clinician to intervene and do something to make the system work.
Can I ask you, just jump in there, James, because I think
Sure.
it may be an appropriate time to say.
Oh, yeah.
So, and I, by the way, and hopefully we'll get into it. And I love aligners. I've been using them for a long time. I've done hundreds of cases. But I think aligners, the concept of aligners is a little bit misleading to a lot of dentists, because I think The fact that you can send something away and get something back means I'm anxious that they thinking that it means that someone else has taken responsibility for the case. In other words, planning, making a diagnosis, and understanding exactly, what it is that we're all trying to achieve. And so I'm sure that you agree that really the most important thing before we start any cases is going through exactly the same process that you would for a fixed case from a diagnostic point of view.
Oh, completely. That's perfect. The idea that you simply take impressions, send them off, and then a series of aligners comes back and it's right for the person. That's not how it works. When you interview the person, you assess them, you take your records, you come up with a very detailed plan for them that's individualized. And then with that, you define your treatment goals and then express that through a prescription. And, I think in South Africa as well, by law, it's required that a clinician prescribe, much like prescribing an antibiotic or anything else. The appliances are prescribed, which include instructions and so forth for the lab. The lab is, if you think of it as, your assistant or your hands to execute the plan. But the idea is the plan must come from the clinician.
Yeah, I just get the feeling that obviously, and I'm not talking specifically at any brand, but I've seen, over the development and obviously there are lots of brands, and I think some are better at making dentists understand that they need to take control of the diagnosis and the treatment plan. And,
right.
And that, that's not necessarily something that is happening that I've seen. And I think that concerns, and that's, I suppose, where the controversy came in with the orthodontic world. I'm talking about the specialist kind of world. And it would be interesting to see how we kind of tackle this problem. And maybe we can talk about it now or later about, orthodontics, dentists, and specialists. How does this all fit in?
Right. You're completely correct. I didn't mention, but one of the other hats that I wore in the past is I was an investigator in orthodontic complaints to our state dental board. And in orthodontics, the highest number of complaints arose out of clear aligner therapy. And a lot of them had to do with the clinician had no plan. In other words, they gave the patient, of course, the fee and an estimated number of steps. But then when things went wrong, and when you looked at the goals, they were unachievable. So, of course, there's no outcome, and that leads to dissatisfaction and the complaints. So that's something that everybody has to be cognizant of, because you could get in real trouble and you could potentially be sanctioned or lose your license over something like this. So again, we have protocols. It doesn't matter if you're doing a restorative dentistry case, implant case, or orthodontic case. We have protocols and requirements for everything from records to diagnosis to a treatment plan that needs to be well documented.
No, that's essential. I think that's great.
Yeah. But as we found, no problem. As we found, though, and I think everybody that's had a piece of technology, it doesn't matter if it's your first computer or your first digital calculator, well, or your first Wi-Fi system, well, often what you receive was not as advertised. And so there was initial disappointment when the first aligners came out. Various societies, people look for evidence. The different orthodontic societies were very skeptical. In the literature, there were some reports that showed, low accuracy of tooth movement, et cetera. There's a long list of things. And so the skeptics were thinking, that's it. It's all over. The end is near for aligner companies. But what happened, if you look at the arrow, is it goes to the future is bright. And that's what I want to spend some time. How did it become from a position of, well, wait a minute, the digital aligners are not what they're hyped up to be, to now what I would say is the world's most popular, and it's the global orthodontic appliance. One of the things that remained in the background that helped focus and get everybody's attention on, it's the constants. Despite reports of low tooth movement accuracy and so forth, and lack of outcomes in the early years, the constants that remained were public interest. People love this appliance, and that continues today. I'll talk a little bit about, why do people like it? I think we have our own beliefs on it and our experience and feedback from our patients, but I'll refer to a couple of quick studies in a minute on the quality of life and also the potential for economic reward. I think this quality of life issue has to get to the patient's chief complaint. I think often we don't do as much of a thorough job as we should listening to our patients and understanding what they're really saying. In other words, if we look at the lower right side of the screen, we have elements that are part of something called a psychosocial impact score. One of them is the aesthetics. Of course, they come in, they say, I want my teeth, I want them whitened, I want them aligned, I want to improve my smile. That's the aesthetic side, and I think we often hear that coming through the chief complaints. But I think it's important also for us to take a moment and think about the other ones. They're really thinking about a bigger picture. When people come in with a small chief complaint, it's about some of the other ones, the self-confidence, the social impact, and the psychosocial impact. And there's studies, and this is one of them, that measures such a thing. So this one was a study that came out of South Korea. They used the metrics of something called the Oral Health Impact Profile, and also from the World Health Organization, an oral health related quality of life, which is the absence of negative impacts of oral conditions on social life and a positive sense of dental facial self-confidence. What they found is that people with malocclusion and fixed treatment, they had the highest oral health impact scores by far, a very statistically significant 0.001. The malocclusion group had the highest psychosocial impact score, while the normal occlusion and retention group had the lowest scores. So this is not at all surprising, and very much like you would suspect. People that had, better smiles, normal smiles, and were post-treatment in retention, they were very happy with life in general, giving all those components. Another one that we think about, and it's particularly pertinent for these times, I think most of you are aware of the economic recession. In my city alone, we have well over 350,000 unemployed people because of COVID-19. And yet here we are at an orthodontic department at a university, and we're as busy as ever. And you think, well, what's going on here? Well, there's more to it. Part of it has to do with the reward for the patient, economic factors, particularly for adults that are in a very competitive market. They want to make their best impression on a prospective employer. So this is one study that looked at dental aesthetics and the influence in finding a job. Basically, they took photographs and they made one photograph of the person with an ideal smile and another photograph with a non-ideal smile. And they showed it to 100 people in HR in various companies, and they had these people evaluate the photograph on characteristics of honesty, intelligence, efficiency at work, and likelihood of being hired. For the characteristics of honesty and efficiency, it was all about the same. But the important thing is people with an ideal dental aesthetics were evaluated as superior with intelligence and likelihood of being hired. And lo and behold, that's a very important part of getting rehired into the workforce. When we think of investigating the broader chief complaint and really speaking and getting feedback from our patients, why are you here? And although, like I said, the chief complaint may sound very cursory, it's about all those other factors that are important. They're after a lifestyle change. And if we look even just at malocclusion by itself, as the run-of-the-mill patients come through, about 75% are affected. And these, if you're not looking, you won't see it. These patients pass through the office, the dental office, every day. Now, this is a good segue into a little bit into what else has happened with clear aligners. So we have the demand, it's always there, it's been a constant. And as I mentioned earlier, aligners have continued to advance and march ahead. There are a few studies on the accuracy of aligners in tooth movement, and I refer you to the right column. You can see what's happened over time. The accuracy of tooth movement has improved.
Can I just jump in? Sorry to interrupt. I think it's really, can you explain how you measure accuracy? So what is it you're measuring to determine whether you're 73% or 57% accurate?
So what's in common with all these papers is they didn't isolate it to a single tooth. They looked at movements of all teeth in the treatment plan in all types of movements, including tipping, rotation, and so forth, and looked at it tooth by tooth. And this is an overall number. So what they did is they did a progress scan, for an aligner step, and then compared it to the digital model of where it was projected to be. And they found there was a difference. They did not quite achieve what the staging would have provided. And so the difference, sorry, go ahead.
So does that mean that the end result won't be exactly what you wanted, or you'll need more aligners, or both?
Exactly. So this is, you hit right on the head here. It is the nature of aligners. Unlike fixed appliances that are directly bonded to teeth, aligners are not directly bonded. So it's no surprise that there is a little bit of treatment lag. And what this means is people have different ways to overcome the lag, and one of them is to do a revision to catch up for that lag. And this is, again, why you need somebody that's a clinician, somebody with experience to see that, okay, this is now lagging, it's not getting where I want it to be, therefore I need to do an action. Sometimes people have used things like buttons and elastics for that troublesome tooth to help it get, to the desired position and so forth. But this is the idea behind why I'm showing this is originally it was thought that patients simply wore a series and you would get 100% of the way there and everybody's happy. But what happened is the entire profession learned. That's what I'm saying is along the way, people learned more about staging and said, I know that tooth is going to be difficult. Therefore, I'm going to overcorrect it, which is a big thing. We're going to overcorrect it. Or in another case, somebody will say, well, I'm going to put an attachment on it and increase my success there, or I'm already going to plan for a revision. So collectively, people learn in the entire profession, and why I say everybody's on a learning curve here. And if you think about it, 2009, 2014, that's not that long ago, but we're getting so much better here. If we implement the latest concepts of staging in conjunction with better systems, everything's improved from the scanners to the software to even materials, and I'll touch on that in a minute. I think we're going to continue to improve our overall accuracy, but it means continued learning for everybody and being a continued student on this topic. In this next section here, I want to speak about the advantages of clear aligners first, and then also the advantages of ClearCorrect system. And in here, you notice the middle, or the third topic, I want to maybe provide a contemporary perspective on why I really like clear aligners, particularly during this COVID-19 pandemic.
Just a question while you get your slide. So what I'm really intrigued in is how many postgraduate orthodontic specialty courses integrate completely clear aligners into their programs these days? Is it the norm? Is it against the norm? What would be the case? I think in South Africa, it's taken a while for the specialist group of orthodontists to really embrace the aligner, and I think that's probably a common thread worldwide.
Yeah, I think all postgraduate orthodontic programs in North America have clear aligners as one of the appliance choices. Now, there are some that each graduate student only gets 1 or 2 cases to treat with clear aligners. And then there's programs like ours that really have an emphasis on aligners because we think that, you know, it's the future of orthodontics. So we're doing everything from early treatment with clear aligners to maybe a different, I guess, a service offering. You know, we are hard hit economically with COVID and everything else. And one of the best things we did was to come up with limited treatments. In other words, we have a full fee. And then for, let's say, a single arch that's maybe up to 16 to 20 aligners, we have a half fee. And then for 8 to 10, we have a quarter fee. And then for just aligners and 2 or 3 steps, we have a 1/8 fee. And that has kept our programs very busy. And this is something that I think, you know, other people could consider. But we do teach across the board all aligner systems, including our in-house made aligners. So in our program, we really embrace aligners because we feel that this is the future of orthodontics. And
I agree with you.
Talk about maybe why. Yeah, sorry.
I said I 100% agree with you there about the future.
Yeah,
is in aligner therapy, or, you know, because of the digital control we have, and, you know, starting with the end result, and so I really agree with you there.
Yeah. And on this slide, one of the main things I want to point out is it has to do with the lack of an orthodontic screening exam, the lack of orthodontic knowledge. And I sense this in many dental programs as they do the new patient assessment. They fail to look at, you know, molar and canine classification and, you know, overjet, overbite. That's not well documented. I think sometimes it's a bit of tunnel vision focused on the caries and periodontal disease. And I encourage everybody in practice of dentistry to look broadly, look at the orthodontic problems. And if you do, you know, you'll be able to tap in on this large opportunity where there's millions of patients that need orthodontic care. And I wouldn't say it's just the restorative dentistry that's guilty of this. I interact with the pediatric dentistry program here, and it was only last year that we introduced an orthodontic examination as part of their general pediatric exam. So they, you know, look more broadly at some of the issues. So again, it's an important thing to include in your practices.
I think historically, like especially in the South African context, ortho has been so closed off as a specialty that any general dentist almost just stood away from it and was able to say, okay, something is wrong, and just refer it immediately. And there is so much room around learning for the general practitioner to say that these are diagnosable things. These are things I need to include as part of my treatment plan process.
Right.
And identify what can I treat and what can't I treat. The same way I would look at a prosthetic case, for example, and be like, this is within my means and this is beyond my means, and refer what's beyond me. Also needs to be treated the same. Yeah,
and I think things are changing. And, you know, our graduates take the dental pledge, and in their pledge, they pledge that they will comprehensively evaluate a dental patient. And that's a change of the times. I hate to say it, but when I graduated from dental school, the mindset was a bit different for general dentists, again, to look for, you know, the restorative and perio and things like that, but have less focus. But I think it has to do with changing economic times as well. But even the dentist pledge has changed to include a comprehensive exam for the patient. And these are some data that you can just look at as far as maybe some touch points in communicating with patients as you're interacting with them in the interview. you may be able to pick up on some of these. This is some statistical data, and there's many reasons why people and why dentists should be involved with improving the smile. The idea of self-confidence, the improved appearance, patients may not readily volunteer that, but as you establish rapport and dialogue, again, it's more than I just want to improve my smile. It's about those other things that we mentioned earlier. And of course, I think like everywhere else, people do not want to appear vain, especially in adults. So part of this also is looking at function. The question is, what happens if I don't do anything, right? That's a common question because they don't want to admit, hey, it's all about the look. No, they want to hear that it's going to have a health impact. And one of them is that, unfortunately, tooth crowding is part of the aging process. The anthropologists tell us we lose 1 millimeter of arch length per decade. Well, that's fine if you're 20 years old, but as you get on in decades and the millimeters start adding up, and that's why when you have somebody in their 60s and 70 years of age, almost invariably people have tooth crowding because the arch length has decreased. So one of the ways of thinking about this is it's anti-aging. You're trying to ward off the effects of aging. Tooth crowding will continue over time. That's well established and documented. But when you have malocclusion, it causes the contact points to change and, teeth that are not, the occlusions off and so forth, the tooth wear. And of course, the force levels change on it. Some forces on certain teeth will cause the so-called abfraction injury, resulting in recession and sensitivity and so forth. And of course, the difficulties with access simply for cleaning and so forth. Those are the more apparent issues. But patients want to hear that, it's more than just about smile. It's about our continued quest, our fountain of youth. Everybody's goal is to try and stay healthy and live healthily as long as possible. And correcting the malocclusion is part of that.
I think you just mentioned one of the most important things, to be honest with you, which is just in this slide. And this changed a lot for me when I was obviously doing consultations for patients, because obviously I didn't embrace orthodontics. And now as a restorative dentist, more than 30% of my practice is orthodontics, and only adults, by the way. But I think it's really pertinent to add, when you're speaking to patients and giving them information, even for a consultation, just for a normal consultation or a 6 monthly or yearly, is that those patients must understand that the malocclusion will get worse in time. You can't necessarily tell them how much. Once they understand that, they really understand that maybe now is the time to do it, because the worse it gets, the more difficult and the more expensive, and all the implications. So it's, for me, changed everything once I introduced this explanation that it will get worse.
Yes, and we deal with patients that sometimes have severe wear, particularly if it's associated with bruxism. And a question that always startles them is to ask them the question, are you aware that the distance from your nose to the chin has decreased over the years? And if they look at a photograph of themselves 5 or 10 years ago, they had more vertical dimension. When the teeth start imbricating, start collapsing in themselves, they do lose vertical dimension, which gives the so-called square face look that is not desirable. In this next slide, we talk about, where this is all going toward health, self-confidence, looking attractive. And this is a perfect fit for clear aligners without the appearance of, all the traditional wires and brackets. There's essentially no dietary restrictions. They have complete freedom on brushing and flossing. And the whole convenience, which I'll talk about in a minute, is really, really important at this point. They could, for whatever reason, lifestyle, stop and start. Adults have complex lifestyles now, and even some children do. people go away for summer camp. We have a number of adults that enlist in the military. They're not permitted to have fixed appliances and be in the military, but they're allowed to have clear aligners while they're in the military, etc. So there's a lot of complex lifestyle changes that go on. And the idea of stopping and starting, as well as the last item here, the remote monitoring options, is really key. I want to take a few minutes to talk about our experiences with clear aligners and during this pandemic. I was, one of the frontline people that had to stay behind when everything closed to see emergencies, and we've been doing that since March. With fixed appliances, we had a number of emergencies, one of which is depicted on the left side. And you really think about that when, whether it be, unfortunately, we have a perfect storm of events here. Not only do we have a pandemic, but we have civil unrest. And I'm sure you've read about it in the news. We had protests, and, right outside of where I live, a policeman was shot and killed right out of my home, outside my home. So people cannot necessarily make it back on a regular schedule. There's a number of complex things that go on here. And with fixed appliances, if there's forces that remain active and one thing breaks or cuts loose, it can really be to the detriment of the patient. So what we have here on the left side is I think you recognize the brackets and the arch wire, but the green is the closing chain. The closing chain broke in the patient's midline, and the elastic closing chain remained active for many weeks and months when the patient should have been seen. But of course, because of pandemic and other events, the patient could not come in. I mean, finally, it got to the point where this young patient's central incisors were rotated almost 90 degrees, and the parent became very aware of it and brought him in as an emergency to take care of it. But we've seen a number of examples like this, whereas if we look at clear aligners, during that period, we had zero. In fact, often we did phone calls, we did Dentigo, and we were able to continue on. We were able to mail patients aligners and continue on. So the whole idea has changed, whereas if you have fixed appliances, they can't do it themselves. If they have remote supervision with a series of aligners, then it seems to be much more amenable to the times that we're facing today. The other aspect of this is, in the back of our minds, with fixed appliances, we're also worried about decalcification and caries that develop. And if patients don't come in, when this all started, we thought it was only temporary. We thought, it would be over in a matter of maybe a month. But as the months turn into 2, into 3, into 4, and so forth, we really worry about those people that have not come in since. Whereas if they were wearing aligners, they simply could take care of themselves by removing the appliance for oral hygiene purposes. And then the other aspect I want to point out is getting back into business. We have a number of precautions, including barriers, enhanced PPE, and air handlers. And the big thing that we're concerned about is procedures that generate aerosols. Well, when we look at our instrumentation for aligner patients versus fixed appliances and what we do, there's much less potential for aerosol generating procedures with aligners. And even if we look at a number of of instruments that we need, I look at a fixed appliance instrumentation and we have approximately 10 instruments on the tray. I look at the instrumentation for a clear aligners and I think we have 2 instruments on the tray. So there's a number of factors that are leading, whether we choose to or not, for more simplified systems that are more efficient. And I don't know if it's COVID-19, maybe Mark, you can comment on it, has impacted your offices as much as it has here?
Yeah, listen, I think that without getting too deep into this whole debate, of course it's impacted everyone. I mean, it's impacted our offices. Obviously, our protocols, which I was involved in implementing or drawing up for South Africa, were pretty strict compared to a lot of the rest of the world, which is good in my opinion. And fortunately, it's not been a horror show for dentistry in South Africa, and I think the rest of the world, in terms of where we are now and where we thought we might have been. So I think dentistry was well positioned because we've been wearing masks, cleaning, sterilizing, gloves for many years. So I don't think the risk was probably as significant as we really thought it was at the beginning. In all honesty, that's my opinion, and that's a good thing, not a bad thing.
Right.
Listen, I think the reason that we should be choosing aligners really shouldn't be that it's going to help us in the COVID era. I think it's because it's a better form of treatment than possibly the alternative, which is fixed in some cases.
Mm-hmm. Right.
Sorry, if I could just add there, I think especially in a South African context as well, we deal with a lot of older patients, so a lot of adults who, realistically, orthodontics and fixed braces as a teenager and as the usual age when therapies like that are carried out, they were just not an option based on our demographic and based on our history, So now we're able to offer them a solution to prevent further malocclusion, to prevent the situation from going worse. And they're more keen to accept it because then it doesn't mean that they're walking around with fixed braces on their teeth that's going to impact them in their professional lives. So there is like a good case acceptance when it comes to adults and clear aligner therapy. Prof, if I can just ask, there's a question that's come through on Facebook now from Dr. Tanda, who wants to know, you mentioned something about the vertical dimension, and he'd like to know what's your view on the vertical dimension and loss of vertical dimension as we age on the facial aesthetic. Like, are there studies to show that it is showing increase in like your marionette lines around the face and the mouth, because the lower third of the face actually does close in quite a bit?
Yes. Another, I guess, big topic for us is also aging and loss of vertical dimension. The baseline is this, and again, there's some data from anthropologists and biologists that as we age and the enamel and dentin wear, we lose the occlusal table. And as we lose the occlusal table, we lose the vertical dimension. At some point, we don't have a compensatory eruption of teeth anymore to make up for that loss of tooth structure. So that is kind of the background. Now, this situation is then accelerated when you have things like bruxism or caries that result in loss of tooth structure because the remaining dental elements take the brunt of the force and it accelerates the wear on those teeth. So what we're doing here is trying to establish, proper occlusion to ward off the effects of aberrant wear and premature wear, I guess you can call it, on the dentition. And so that's an important part of this. And we have examples where people have had, particularly the bruxism patients, accelerated wear, tremendous wear on the teeth. And of course, you see the drastic changes in vertical dimension. And if you have some time, just do a Google search for something called square face syndrome. And you can see all these people and a lot of information documented on what exactly happens with that, including there's some osseous changes as well. They get the sclerotic phenomena that you can see on your panoramic or your cone beam CT, and flaring of the gonial angle. It flares out so that the gonial angle comes out because the imbalance of the master muscles, and that contributes to the overall squareness. So there's a lot of literature on that topic, one that I actually give CE courses on. So, but I don't want to take too much time on it, but yes, it's an important consideration for managing some adult patients.
I have to say, obviously, that is quite a controversial subject, because, at what age, first of all, do we lose the compensatory eruption? I wasn't aware that I've seen many old patients who, if we pull teeth out, they still get eruption of the opposing tooth. So I'm not sure. I agree that the tooth wear has to be extraordinarily quickly not to get compensatory eruption. But most wear cases happen over 3 decades, not over 3 years. And so as a result, I think that the square face syndrome might well be more to do with just the development of the masses. So, kind of rather than a loss of vertical, because I don't think there's an answer to this, and I agree we shouldn't get caught in this, because there are some studies where they show that even a loss of up to 6 millimeters is not possible to be determined from a facial appearance. Yes, if you measure, you can determine, but from an aesthetic appearance of a facial photograph, it's not possible. So in other words, opening the vertical, I'm not talking about loss. So the reverse, because often we open the vertical as a solution to restorative dentistry. But I think that it's that's a difficult one. I mean, I would appreciate if you can send us the articles that you were talking to. That would really be helpful to our group. So any article that you had that relates to the vertical, because we had a really cool discussion just the other day. So let's not spend any more time on that. If you could send those articles, I'd really appreciate that.
Yeah, and the last thing I would add is we are looking at this in quite depth. And so with patients that Brux, we do a nighttime myo monitoring. We have a take-home monitors which are surface electrodes, and we get some baseline data on it, and we're following those as well. And of course, maybe it's controversial in South Africa, but we are injecting botulinum toxin in their masseters.
Not controversial.
It is or isn't?
No,
it isn't.
Oh, okay. All right. So yeah, that's one of the things that we look at, and then we do post-op measurements as well to see what's happening with the bite force. But yeah, we'll follow up with that discussion. This, while we have it up, this is probably one of the most, I guess, pertinent slides that I'll have, and it talks about the change in the thought process and where ClearCorrect fits in with this. And early aligner staging concept, and myself, admittedly, as part of it too. The original thinking process was to have attachments on the teeth early and start moving them with attachments. And if there's complex tooth movement, let's say rotations of conical teeth, like lower first premolars, we'll put attachments on them. They're absolutely needed. And when we follow that concept, though, the result is when you look at an aligner staging plan, that about 60% of all teeth, whether the attachments are there to retain the appliance or to actually help with the movement, about 60% of all teeth had an attachment. Because the evolution of materials and also aligner design, and I'll talk about our design in a minute, is that the strategy has changed. The first step is to create space, develop the arch form, expand, and it's up to the clinician where they want to do it. Is it only limited to anterior expansion, in other words, proclination forward, or is there going to be a little bit of expansion that you take from the premolar area and start going into the posteriors? And then the aligner design alone can manage a great deal of these complex movements. So that means if you take advantage of the aligner trim line of ClearCorrect, you can do a lot of these movements and get you a long ways there. And I'm saying this with some research. We published in the Journal of Aligner Orthodontics on rotations, and attachments do not confer as much boost, as it were, compared to a straightforward trim line. So if you are going to deal with complex tooth movements, go as far as you can, but use the extended trim line, add your overcorrection to it to take up the lag, and then at the end, we've shifted. I'm not saying that attachments are not necessary. I would say that you can eliminate, and as I show the cases, I want everybody to pay attention to the number of attachments used. There's going to be some cases that I show that are from various practitioners, but just look at the minimized use of attachments for the ClearCorrect cases. But attachments are used later on as a last measure. And generally that's music to everybody's ears, because I don't think any dentist or any patient likes attachments. In fact, that's one of the sources of complaints about patients when they say, hey, I signed up for these so-called invisible appliances. Why do I have all these bumps on my teeth? It's a source of dissatisfaction. But if you can say, well, we could do most of your treatment without any attachments, and then maybe at the end, we'll have to do something like an attachment, or in some cases, you can do a button on it, on the tooth with an elastic to resolve the issue. So I'd say this is the single most significant shift in the concepts of staging in general, compared to what we did, let's say, even 8 to 10 years ago. So added to our, and again, the whole profession was learning, and why we continue to advance from that modest 41% to now in the 70-some% accuracy is thinking like that. And another advancement would be the materials, and this is where ClearCorrect has recently introduced the clear quartz material, which is a tri-layer material. It's got a hard outer and a thinner, more flexible inner layer sandwiched in a very thin, it's only 0.75 millimeter thick material, but it allows a better force relaxation, almost like the nickel titanium arch wire for orthodontics. And this is nice to have that extra flexibility, particularly patients that have severe malocclusion or very proclined incisors. I think most of us have seen incisors that are so proclined, you can't get a good path of draw. It's really difficult to seat those aligners because the teeth, or teeth that are maloccluded in opposing directions, right? It's really difficult to get a path of draw, and often we end up cutting the aligner in pieces and so forth to get it to simply to seat. But this material is much more flexible, so we'll be able to capture many more of those cases without having to do anything extra like that. And I think the sustained force is also going to result in more comfort, particularly early on. Over time, you know, it'll dissipate, but over time it'll be more comfortable. I guess at first, with the historic material, it was more of a snap fit. You could hear it when you put it in a patient. You could hear even the snap fit. With this material, it doesn't have the same fit because the force is more gentle over time. Another really important thing is the resistance to staining. Adults are often into coffee or tea, and if you look at this study that just came out in February of 2020, they looked at different brands of aligners and the staining under, in solutions of red wine and Coca-Cola and tea and so forth. And if you look at the ClearCorrect, it performed the best out of all of them. I think another takeaway is black tea is probably the worst thing you could do. Drink black tea because it doesn't come off. And even with the cleaning agents, you can't get these stains off. Now, we add to that the ecosystem that Strong has provided, which allows, and I mentioned one of the tools that we use is the Dent2Go, to be able to do the monitoring and surveillance of the patient, and to give a fairly comprehensive feedback from the patients on the aligner wear and whether or not to continue to proceed to the next one or continue with the same aligner. But this system allows for introduction of other aspects of dental care, everything from whitening and so forth. So that's just something that Straumann provides. There may be some users new here, But ClearCorrect is great in the sense that they're agnostic as far as intraoral scanners. So any kind of scanner will work with ClearCorrect as long as it outputs into the common, what's called the .stl file. It'll be accepted by ClearCorrect. So as far as the material compared to what's on the marketplace, it probably has this, I think the new Zendura Flex is probably the most state-of-the-art material available right now. I mean, there's a 2-layer material, but having the 3-layer material, and by the way, the 2-layer material that's out there, one of the reasons why it stains so much is because there's the 2 layers, there's a hard layer and a soft layer. And because there's nothing covering the soft layer, it easily picks up the stain, and it'll show within days. Whereas with the 3-layer material and having 2 hard layers, one on the inner and the outer, it's much more resistant to the stain and discoloration. So the trim line, I'll talk about our study in a minute. But the other thing to add to this combination is the new software called ClearPilot, where it gives a lot of visualization and control to the user. I think, I'm not sure how many people have logged on. It's still relatively new, but it puts everything on the same page. And I'll share with you in a minute the tools that I use the most. I'll share the interface here. The tools that I really like is down here, the treatment overview illustration. It shows you which teeth are active in the lower left. There's also the tooth movement chart here. Those ones, probably those two, and the superimposition tool are what I use the most. The superimposition allows for a comparison of any step to the starting position of the treatment. But it's nice that everything is there, and you can easily, as you're rushing around between patients, you can easily get the information you want out of the software. So I really like that new feature.
Sorry, Prof, just to stop you there on the software, does it allow you to place attachments as the user, like as a clinician to? Not
the early version. That's planned in later versions. Okay. Yeah. At this point, I want to spend some time talking about the trim line and why that matters. And I'm going to cite a study that we performed in 2012 in conjunction with the Department of Mechanical Engineering. At that time, there was not a lot of publication or anything on how aligners can be trimmed. And basically, we looked at the trim lines shown here. I think you'll recognize the trim line on the left. That's a scallop trim line. And the scallop trim line does not have any of the plastic crossing across the interdental papilla. The one in the middle is simply the flat trim line at the gingival zenith. So this is what you commonly would do if you're making them manually and you're trimming the plastic with scissors. It's the easiest to cut. You just follow the apices of the gingival zeniths and cut it. But then we were aware that occasionally if you extended the trim line, the appliance would fit like a full complete upper denture where you actually had some suction on it and it would be more retained on the teeth. So we asked the question, if we extended it 2 millimeters above the gingival zenith, what would happen to the retention on it? So we made some typodonts with the different trim line, and we brought it over to mechanical engineering. This is a Instron, or universal testing machine, to study retentive forces. And what we found is, if you look at, I'm going to only focus on, there's 2 areas, group 1 through 3 and 7 through 9, that I want to focus on because that's with the clear materials. The other one's with carbonate material. But the first thing I want to point out is group 1, which is the scallop trim line with attachment, and group 7, it's the same scallop trim line without an attachment. And we were quite surprised. If you scallop the trim line and use an attachment, it makes it less retentive. It worsens it. And if you look at the amount of ideal retentive force, which is a straight line pull off of this, is 12 pounds. If you look at the group 2 with attachments, which is a straight line trim, you were above that. And of course, if you have an extended trim line with 2 millimeters extension, the retentive force was excessive at 22 pounds of force to dislodge the aligner. Whereas if you looked at simply a flat or straight line trim, which is group 8 and no attachments, it was just under. But if you extended it by 2 millimeters, it was much more retention. And you might ask at this point, what's the big deal about retention? The big deal is for aligners to work, they need to be seated. They need to be retained on the teeth. And just like the fixed appliances, if the wire is outside the bracket slot, you're not going to get what you want to do. So retention is the name of the game here, to allow the plastic to work and allow the teeth to move.
What about thin biotypes and maybe recession and being careful about, you know, what's going on? Is there any kind of mention when you're doing your diagnostics about exactly what's happening?
Yeah.
I mean, even from a moving tooth point of view, this always worries me, that dentists, you know, you don't have any idea about actually the bone volume, the biotype, you know, and now we're moving teeth outside of the arch. Yeah. I think sometimes dentists really don't understand the dangers that are there, you know, with these kind of procedures.
Yeah, this gets back into, you know, the fundamentals there, knowing the alveolar bone, the gingival biotype, and the limits. And that's one of the, maybe I would say that's one of the more important concepts of our biomechanics, is to know the biologic limits. And again, this is kind of against the myth of you simply take scan impressions and send it in. Well, not everybody's the same, and we have to respect the individual differences. Of course, you know, we do our complete periodontal exam and clinical exam. And, you know, at the university, we do take cone beam CT scans on everybody. And we have a good look. But it, you know, again, underscores that, you know, there's some complexity to aligners. It's not so straightforward. And so with this, you know, try and explain what happens with the plastic. Basically, the scallop trim, it obviously removes plastic from the interdental papilla area, and you lose rigidity in the lower third of the aligner. And there's not enough material then in the upper 2/3 of the crown to adequately cover and remain adapted around the attachment. So it easily releases. And again, a way to think about it, again, is the best fitting complete upper dentures have incredible suction on those. And in other words, a scallop trim line with an attachment, it actually interferes with adaptation of the aligner, the plastic around the tooth, and the loss of rigidity allows the excessive flexure in the region so that retention is decreased. And if we go the other way, adding more plastic material to adapt and secure the aligner on the tooth when using attachments, attachments used with straight and extended trim lines produce increased retention, because now there's enough plastic to cover not just the tooth, but the whole attachment.
So one quick question about attachments, because I think that, again, that's a super important part of it's an integral part of clear aligners, you know, regardless of which system you use. Having said that, I have seen some aligner systems that don't really use attachments, and exactly. You know, I just wonder, you know, that some dentists, you know, who are entering into it must understand the complexities and the need for attachments. But an interesting would have been a study to see how accurate the attachment bonding was done, you know, from one dentist to another, because obviously the accuracy of the attachment when we're bonding it to the tooth has a massive impact on the success of the case. And my concern is often that bonding procedure isn't exactly going as it should do, as obviously the computer programmer, whoever it was, wanted us to do. So yeah, I'd be interested to see a scan of the actual how they were bonded and what the computer wanted. I think that's a big problem.
Yeah, you're completely correct. This is one of the open areas of research with aligners. You recognize all the steps of placement of the attachments. Sometimes, there's issues with bonding. There's continued issues with wear and tear on the attachments. And I think many times the material used is a flowable resin, which doesn't have the best wear characteristics. And so there's a number of issues around attachments. And add to that the, enigma in the literature. Can you believe that in the literature, there is no attachment design that is superior to the other ones? In other words, if you have a standard rectangular attachment, it's as good as any of the other attachments. And despite people having generations of attachments with their appliances, there's no study to show efficacy of adding all these other attachments. And for that reason, you may be detecting a bias in my thought process. I am not a big fan of attachments. I recognize in some situations they still are necessary, but their role in my mind is less than what was originally envisioned. That they were doing all this stuff, they were torquing and doing tremendous movements, and then you look at it and say, well, wait a minute, it's more the aligner that's doing it than the attachment itself. And without, getting too deep into it, I'm also an adjunct professor at the University of Alberta, where we have an orthodontic simulator, and we're conducting these tests it's basically a full dentition with mechanical force transducers on each and every single tooth. And so when we apply an intended movement, such as torque, which is one of the controversial ones, with and without attachment, is there going to be a difference? So we have a PhD student working on that, and hopefully we'll have some answers as far as what advantage or not that attachments confer to the system. In our study, we used a 2 millimeter extended trim. Looking at the numbers, the clear correct trim line backed off a little bit, 1.5 millimeter. And I want to talk about that in a minute. The 1.5 millimeter, unfortunately, there's a misconception that the 1.5 millimeter extension will impinge on the gingiva. The first thing I would say is if your scanner, the impression is accurate and it accurately replicates the gingiva, it shouldn't impinge on it because it's accurate, right? And then even if you extend to cover it, 1.5 millimeter is not that much. If you take out your millimeter ruler and you look at it, it's not. But the idea is it's the 1.5 millimeter extension that is on every tooth going around the arch. If you go around the arch, then collectively it makes a difference. An analogy I have is when people tell you, the water level in the ocean has risen by 1 inch. A person would say, well, 1 inch is not that much. Well, yes, it is on that kind of scale. And so that's how the trim line works. Every tooth being extended adds to the collective retention of the appliance. And when you're able to do that, you get much more retention and thereby allowing the appliance and the plastic to work as you planned, and you can eliminate a lot of the attachments.
That's amazing. So it's been fascinating, this talk. I could honestly go on for another 6 hours. But I think our kind of general was we were going to try and keep it to an hour, but we've gone way over an hour. Maybe, which is awesome, by the way. As I say, I've got so many things I could ask. Maybe if you'd like to kind of finish with a case or do something that you think is really important in the next couple of minutes.
Sure.
And yeah, just because, I'm cognizant of that, it's Friday and we've gone beyond an hour already and we just like going on and on. We can go on for hours. But maybe just to give you the heads up that maybe in the next couple of minutes, 5 minutes, we can do a case or whatever you feel is really appropriate.
Yeah. Okay. Just quickly to finish on the trim lines, you still need to look at the patient and see what they have. there are patients, and there's examples, and you can find this on ClearCorrect's literature as well. You don't want the black triangles or people that have excessive recession or abfraction. These are all the listed exceptions where you can ask ClearCorrect to back down on the trim line, because if you use extended trim line, you may have differences with path of draw and so forth, or some implant designs have extreme undercut. Similarly, underneath the bridge, you have to make the technician aware of it. So, and it's not often apparent looking at the scan that that tooth is an implant, by the way. So the dentist needs to inform the patient of these type of situations where the trim line, it needs to be reduced to at least a straight line trim so that there's not over or too much retention. So I'll finish there, and then let's get into some of these cases. And, like these cases will come from, this is from Dr. Fisher, but I wanted to show an assortment of these cases and what's very predictable. But the main thing is look and see, this is obviously a very beginner case, but the minimal use of attachments in these cases. This is, simple, a little bit of upper and lower crowding with a bit of rotation, and the patient complained a little bit of heavy occlusion in the anterior. These are very predictable and very doable. This was treated with 6 sets of aligners in 4.5 months. Now, one thing that it is part of maybe informed consent is you notice in the right side here, and when you have 2 incisors that are overlapping in an adult, by the time you align them, often there's a bit of a black triangle. So that's there. It can be resolved in a number of ways, but that's just part of the informed consent. So these are some of the other views of the same patient. So here's another patient, slight crowding. Again, these are beginner cases, very easy, very predictable. We'll get into the cephalometrics. But this was 10 sets of aligners, no attachments, 5 months.
Sorry, Prof. So am I right in understanding that the reduction in the use of attachments is coming from a combination of the type of material and the trim line in order to achieve the movement?
That's completely correct. Yes, you're getting it, first of all, to retain.
Okay.
It's seating the liner and staying there, which is what Henry Nahom told us in the 1960s. You need to keep chewing on it. But if it stays down, then it allows the plastic to work and then implement the planned tooth movement.
Okay.
And so this is some of the other views of this patient. Now this is another moderate case here. This is about 20 aligners. Obviously, if you look at the upper right, there's a little bit more arch length deficiency. There's some rotations involved. And another one that was treated without attachments here.
I mean, as soon as you need, obviously, more complex movements, rotations, extrusions, intrusions, you need attachments.
One of my cases that I published in the Journal of Aligner Orthodontics last year, hyperdivergent patients are a little bit tricky. In fixed appliances, you can overly open them if you're not careful. So this patient had, starting out with a minimal overbite, and if you put in a fixed appliance, you can easily lay out the lower incisors and procline them to the point where she has an end-to-end overbite. If you look at the lower, that's the complicating thing here, is she has a moderate arch length deficiency if you look at the lower arch, which is really tough. Now you've got somebody with a tight overjet, moderate arch length deficiency. Unless you do a ton of interproximal reduction, you can really procline them and make their situation work. So again, following the concept that I mentioned earlier is go as far as you can without attachments. And then when you see that there's some lag on some teeth, we went up to 9 aligners, no attachments here. At aligner 15, and this is where, hey, the canines are difficult teeth to rotate because of their morphology. Only 2 attachments were placed on the upper canines. So this is after 15 steps. And after 18, I think we had a little bit of a rotational issue, the lower lateral incisors, you can see here. We needed attachments on those two.
How do you plan for that then? Do you put, is it all in that initial setup that you would go up to stage 9?
That was a revision. We went
revision.
as far as we can without, and when we see that there's some lag,
then you restart again.
Yeah, and then we ordered a revision with attachments on those teeth. And then this is after 22 aligners. We removed the attachments, and one of the things I like to do is remove attachments and then have 1 or 2 steps without the attachments. So 25 aligners. If you look at her overbite and overjet, knock on wood, it stayed the same. We didn't reduce it. And then she's finished after 27 aligners. And if you look at the lower arch, we're able to resolve the arch length issues without excessive proclination. There was IPR done, but I won't go into the details of cephalometrics, but for the orthodontist in there, suffice it to say, we managed to correct her malocclusion without changing her vertical dimension. So those are the cases I'd like to show, and I'd like to summarize just quickly 2 slides, and then I'll shut up. So when we're getting into it, it's really important to look at this. I know it's a busy slide, but as people progress on their own individual aligner journey, it's important to know, if I look at the middle column, as you get into more areas of tooth movement, you're going to have some accompanying skill sets. So originally, if you look at simple teeth, you just need, you look at the ability to place attachments and an interproximal reduction. But as you get into treatment of both arches, then you get into maybe use of auxiliaries like buttons and elastics. So there's a progression here. Particularly if you want to change the molar classification, going from, changing the molar classification is a big step. So there's more complexity to it. And as you get into, extractions and so forth, there's a lot more. And it's a long journey. I mean, that's why there's a specialty of orthodontics. But I think it's important for people to build up the skill set and progress through it. And at the end of the day, I want you to look at this concept. Every clinician wants to have a trouble-free practice. You want to be able to be efficient, happy customers, and you want to think about this. Where are you going to be positioned? Is it better to treat 2 patients that go on for 18 months, or do you want to take on that one moderate to severe case and deal with it for 36 months? Certainly, there are individuals that are skilled enough and have enough experience. There's no trouble to finish that patient. But this seems to be one of the pivotal things for people when they get into aligners, to develop the judgment of which ones can I confidently do and which ones should I avoid for the time being until I develop my skill sets to do so. And I think that's should be on the top of everybody's mind that's on the learning curve. So with that, I apologize for going over time, but I think we had a good, fruitful discussion, and I think we have some time if there's any questions or anything like that.
No, I'm just going to say one thing, and it's going to be a yes or no. No. So here's just one thing to think about, obviously, is what do you feel about the vibration devices like Propel V-Pro Plus, for instance, in terms of enhancing or accelerating aligner therapy? Good or bad?
Yeah, basically, I think they work by helping seat the aligners. There's everything from the light, right, the blue light, to others, and what they have in common is they serve to seat the aligners. So I think another way to do it is to prescribe the use of the chewies, or sometimes we give them the saliva ejector tip so they can work on that area to continue to seat the aligner. But so far, when you look overall at the literature on it, although there's sporadic reviews that there's some difference during a specific phase of tooth movement, overall, there hasn't been much of a difference.
Mary, you can do the final and thank Prof for that. Thanks, James.
I think we all learned a lot, and it's definitely a topic that we can go on speaking about for hours and hours. There is so much more to learn, and if you could pop through any literature you have or any insights, that slide you had on the staging, the one you showed just before this, was actually really great, and I think our members would benefit to see where they fit into delivering aligner therapy. Thank you for your time. Thank you for bearing with us on a Friday afternoon, evening. It's now nighttime. Hope you have a lovely weekend, and thank you, Prof. James Mah.
Thanks, everybody. It's been my pleasure.
So, James. Bye, Mary. Thanks, everyone. Bye.